Okay, great. Thank you very much. And yeah, I hope you had very inspiring and great discussions in the breakout sessions. And yeah, and I'm happy now to take over the chairing of the coming sessions, where we have another 4 very exciting presentations where I'm very much looking forward to. And yeah, of course, the principle is the same as for the first sessions. Please again send your questions in the chat to the host during the presentation. Whatever comes up, just yeah, post it in the chat. And then after this session, we will have again a question and answer opportunity. So then now I would like to invite our next speaker, Professor Rebina Sarkar, to yeah, to start her presentation, to share her screen. And Professor Sarkar is professor at the Department of Public Health at the Institute of Social and Cultural Studies at the University of the Punjab in Lahore, Pakistan. And she will talk to us about the health status and healthcare utilization of Afghan refugees in Pakistan. And yeah, I'm very much looking forward to your presentation. Thank you.
Thank you very much, Dr. Schmidt. Thank you very much for a very interesting talk from different speakers. I will talk about health status and healthcare utilization of Afghan refugees in Pakistan. And as you know, the Afghan refugees, they are the big group of immigrants to different countries in the world, and similar is with Pakistan. So I will talk a little bit about refugees in Pakistan. Because of continued civil war and a lot of other political problems in Afghanistan, many of the Afghanis, they flee because of violence, political oppressions, and because of economic instability to different countries in the world. And the Afghanis, these are currently the second largest refugee group after the Syrian refugees. And Pakistan is home to 1.4 million Afghan refugees. In 2016, Pakistan was the second largest refugee hosting country after Turkey. Because the first wave of Afghan refugees to Pakistan, it was started in 1979 to 1982, when there was Soviet war in Afghanistan. And at that time, around 2.3 million Afghanis, they migrated to Pakistan. So here you can see different numbers of Afghan refugees who are coming to Pakistan during 2002 and 2020. In 2002, around there in Pakistan, there were 3 million Afghan refugees. But now you can see currently there are about 1.4 million registered Afghan refugees living in Pakistan, because there are many refugees who are not registered, because I am talking about this figure 1.4 million for those who are registered, because registered means they have the permit of residence and they have the permission to live in Pakistan. But there are many asylum seekers from Afghanistan as well, and many of the Afghanis, they are coming to Pakistan for business purposes, for medical reasons, or for other different reasons. After the first wave of Afghani refugees to Pakistan, many of them, they repatriate back to Afghanistan. So here you can see the number of voluntary return of registered Afghan refugees from Pakistan during 2002 to 2020. So around 4.2 million refugees, they went back to Afghanistan during this time period. But still we have 1.4 million registered Afghanis living in Pakistan. With respect to location and the age and gender of refugees living in Pakistan, many of the Afghan refugees, they are living in Afghan refugee villages. Because many of them at the time of different wars and political instability, most of the people from Afghanistan, they were living in camps which were at the border of Pakistan-Afghanistan border. So, but many of them, they also moved from these Afghan villages to urban areas, for example, to Karachi, to Lahore, to Peshawar. So if we see the statistics, around 32% of the Afghan refugees currently, they are living in urban areas, and 68% they are living in Afghan refugee villages. When there was first wave of Afghan refugees to Pakistan, at that time, Pakistan established 300 Afghan refugee villages in Pakistan. But with the passage of time, when many of the Afghanis, they went back to Afghanistan, then all these villages, these were closed, and at the moment in Pakistan there are 54 Afghan refugee villages. If we see the age structure and the gender of these Afghan refugees, there are more or less similar number of male and female, and around 23% of women, they are less than 18 years of age, and around 23% women, they are in the 18 to 59 years age group. Only 2% women, they are more than 59 years age group. With respect to male, 28% they are adult, like in the age group of 18 to 59, and around 3% they are more than 59 years of age. Here you can see the Afghani who are living in different provinces, because KPK, Khyber Pakhtunkhwa, this is the province of Pakistan, which is very near to Afghanistan, and it shares the border with Afghanistan. So most of the Afghani, they are living in KPK, and most of the Afghan refugee villages, these are also in KPK. But around 10 of the villages, these are in Balochistan, one in Punjab, and most of the other Afghan population, they are living in Sindh, Islamabad, and other locations, and mostly they are living in the urban areas. So if you talk about the health status of Afghan refugees, because the Afghanis who are living in the Afghan refugee villages, their living conditions are not very good, because most of the people, they don't have access to basic needs, for example, the education, health facilities, and as well as they are living in overcrowding, and they are experiencing a lot of problems. So all these factors, these are affecting their health. Because Pakistan is the country where is a developing country experiencing a lot of economic and political instability. So that's why it was very difficult for Pakistan to provide economic facilities to all the refugees and all the people who are coming from Afghanistan to Pakistan. And the other reason was that many of the population from Afghanistan, they were not very well educated. Only if you talk about the statistics, 71% of Afghans who are registered in Pakistan, they don't have formal education. And specifically, if you talk about women, only 18% of the girls, they are enrolled in schools, and with respect to when you talk about males, they are 54% males, they are boys who are enrolled in schools. So and many of them, they are not involved in employment, and they are involved in small businesses. So they are not producing enough for the country. So that's why the living condition for them, this is not very healthy. And the other thing, because many of the, when we talk about the refugees, they are more susceptible to local diseases as compared to to indigenous population, because if they are coming from the areas where which are non-endemic for different diseases, and they are coming to endemic areas, for example, KPK, but many of the areas, these are endemic for malaria. So they are susceptible to such kind of infections and diseases because they are not immune to such strains of viruses or bacteria. So this is the reason that they are more susceptible to different infection. And Pakistan is the country which is still experiencing double burden of disease. We have a lot of communicable as well as non-communicable diseases. So this is similar to the local population, Afghani population. They are also experiencing communicable and non-communicable diseases. And if we talk about the death among Afghan refugees, this is mostly because of cardiovascular problem. And if we see the total rate of cardiac patient, it's 6.67 per 1,000 population. And the most common infection among refugee in Pakistan is the respiratory tract infection, because one of the study has reported that around the people who are, if you see the burden of disease, 48.05% of burden of disease because of communicable diseases is due to respiratory tract infection. And then the skin and diarrheal diseases, these are also common among Afghan refugees. With respect to skin diseases, leishmaniasis, this is also, there are a lot of cases of leishmaniasis among Afghan population. Here you can see the causes of mortality among Afghan refugees due to communicable and non-communicable diseases. As I already told, that cardiovascular diseases, these are the most common factor for mortality among Afghan refugees. And here you can see the different number of deaths due to cardiovascular disease between 2012 and 16. If you talk about other infections, although there are not much infections related to measles and tuberculosis, because Pakistan is the fifth country with highest number of tuberculosis cases. Initially, when Afghan refugees, they migrated to Pakistan, there were a lot of cases of tuberculosis among these population, because they were living in poor and unhygienic conditions and in overcrowding. But with the passage of time, because of there were a lot of programs going on from the United Nations High Commissioner for Refugee to improve the health status of Afghan refugees. So that's why now we have less number of cases related to TB and malaria, because when they came to Pakistan, there were epidemic of malaria among Afghan refugees living in camps, or you can say the Afghan refugee villages. So this was the reason that the government thought about to start malaria control program in those villages, and now we have very few cases of malaria and tuberculosis among this population. When we talk about the maternal health outcome of refugee population, especially women, it's the maternal health outcomes. This is not good, because women, men they are experiencing a lot of mortality, but women, they are experiencing morbidity. And one of the main reason is maternal health outcomes. The main reason is in Afghani population, marriages are early marriages, and you can see the child marriages, which are the marriages less than 18 years of age. And many of the Afghanis, they are not very towards using contraceptives, and the husbands, they don't agree with this. So that's why they have multiple pregnancies. Because of early marriages and multiple pregnancies, the maternal health outcome is poor. And many of the, according to one study, many of the mothers, they are experiencing problem of anemia and hypertension. This is also very common that they don't start prenatal care from the first trimester. Mostly women, they start prenatal care in the third trimester, and this is the reason that because of different pregnancy-related complications, there are high mortality, maternal mortality among women. So when we talk about the child and infant health, there are a lot of preterm births because of early marriages and as well as poor nutritional status of mothers. And the births are mostly underweight or low birth weight. Postpartum depression, this is also common among women. The one reason is that they don't understand about the disease, and so that's why they don't take necessary treatment which is required for the postpartum depression. So the maternal deaths account for substantial burden of mortality among Afghan refugees, because Afghanistan still, this is a country which is at the second number in the world with high maternal mortality. And this is the case when they are in Pakistan. They have the same belief system and tradition that women, they can't decide about their reproductive health, and the reproductive decision making is mostly in the hands of men. So that's why this is the reason that many girls, they are, and the women, they have high maternal mortality. So the other reason, because Afghanistan is a very traditional country, mostly decision making is in the hand of males. So women, they don't have much decision making in the mobility and deciding about their health, their healthcare utilization. So this is the main reason that they do not access the healthcare and the resources. Because of access to healthcare resources, this is minimum. This lead to adverse health outcome for these women. And the other reason, because of multiple pregnancies, they have high birth rate and low rate of family planning use. So all these also factors also affect their maternal health outcome. When we talk about the reproductive health of Afghan refugees, reproductive tract infection, these are very common among women. And according to one of the study which was conducted in the 7 basic health units where women, they visit to take treatment, around 76.6% women, they have the problem of vaginal discharge, cervical prolapse, or dyspareunia. And many of the women at the time of checkup, they found that they have cervical prolapse, and they reported that they did not seek any care for such problems. Many of the studies, they have provided evidence that because the reason for the poor reproductive health of women is basically early marriages, which is 54% of the women in Afghanistan still they marry at the age of less than 18 years. And because of poor living condition, poor hygienic sanitation, and these are the conditions and the factors which lead to high reproductive tract infection. If we talk about hepatitis B infection, it's also endemic among Afghan refugees. The reason, because some of the studies, they have reported that the use of injection, it is very prevalent among the population, because they think that for minor illnesses, injection is necessary, and especially if they are going to quacks or if they are going to private clinics, then it is very easier for them to get these injections. So because of these unsafe injection practices, still the cases of hepatitis B are higher among the people who are living in Afghan refugee villages. According to one study, the prevalence ratio or rate of hepatitis B surface antigen was 8.3% among Afghan refugees. Similar is the case with the diarrheal disease. Diarrheal diseases are also very common, especially the people who are living in the Afghan refugee villages and the people who are living in Kachi Abadis, because when they go to urban areas, mostly they are living in the urban skirts, and here the Kachi Abadi means that the informal settlements where they live, and because of the poor sanitary condition and the use of contaminated water and poor personal hygiene, intestinal parasitic infection, these are very common. Similarly, I already talked about the malaria and the mental health problem. This is also a very high. There are many cases of mental health issues among refugees as compared to non-refugees. If we see the psychological disorders, it is 0.22 per 1,000 population. Lack of social poor living condition, all these factors aggravate the condition of poor mental health among this population. The one very important factor which I want to discuss is the domestic violence, because the domestic violence, it affects women's health. And when I say the reproductive decision making, because the domestic violence, this is the factor which hinders the reproductive decision making power of women, and especially the population living in areas where there are less opportunity for employment, and because of economic issues, there are a lot of conflicts between husband and wife, and most of the time husbands, they are more authoritative and control all the earning, and sometimes it leads to and other factors as well, because there are not only a single factor of poverty, but there are many individual and structural factors which are still in Pakistan. Because of this reason, Afghani population, they are experiencing a lot of problems with respect to domestic violence, and there is less awareness related to sexual and gender-based violence, and so there is a strict need of multi-sectoral approaches to combat sexual and gender-based violence, especially the training of the healthcare providers, and healthcare response is very much important, especially the guidelines and protocols which are used in different countries. These are not still used in Pakistan, and there is a strict need, urgent need, that such kind of protocols should be used to screen such kind of cases. When we talk about the healthcare utilization, refugee, they experience a lot of problems and challenges. For example, when they enter, at the time of entry, there is no standardized health examination. And most of the time, the screening focuses on infectious diseases only. And there is no, they don't provide clinical preventive screening, and there is no standardized protocol for the referral of these patients if they diagnose these cases, and how and where to refer these cases. And one of the very important factor which is missing when healthcare, these refugees come to Pakistan, that the assessment of contraceptions or preconception care, which is totally missing in the assessment, because they don't talk about the contraceptive needs of these women, and especially when they come here, there is less support for resettlement to integrate them, their cultural orientation, and there is no such system which can provide health insurance to those people. And so the major problem refugees, they are experiencing, this is accessibility of healthcare facilities to those population. And when we talk about the refugee health assessment, this is not provide any preventive screening or the referral to the primary care. So primary healthcare providers, these are not familiar with the refugee screening guidelines. They don't know about their culture and their needs with respect to health. So these are the factors that sometimes it leads to delay in accessing primary care, and time to first appointment is always delayed. And sometimes most of the women, they don't go to male healthcare providers, and if male healthcare providers, these are not available, it also create a delay in seeking care. So there are other factors as well which delay the appointment with the healthcare providers. So there is an urgent need that the screening guidelines and checklist should be used for the systematic assessment of refugees' health, and guidelines should include not only infectious disease, but as well as also cervical cancer, intimate partner violence, and the contraceptive needs, as well as mental health of this population. For improving the access to primary health care, it is very important that there should be collaboration between the multidisciplinary staff, and as well as low-cost services should be provided, because if there is a huge distance between the village and the health facility, so this is less likely that the people, they will use the health facility. So if there is distance, then the services should be provided in this way, that the outreach services to the at the doorstep of villages should be provided. One thing which is very, very important, that is use of gender concordant providers. So in case if they are women, they are not willing to go to male providers, there should be some female providers who can provide health needs of these women. So thank you very much. I think I'm in time.
Yes, thank you very much for this very insightful presentation, Professor Sarkar. And I would now like to move straight on to our next speaker. And please, for the audience, remember that you have the opportunity to ask all your questions into the chat and send them to the host. So I would now like to invite Professor Mubarak Hasim Khan from the Department of Social Relations, the Faculty of Liberal Arts and Social Sciences at East West University in Dhaka, Bangladesh, to share his screen and to give his presentation on Rohingya refugees in Bangladesh, challenges and strategies. So I give the word straight to you. Thank you very much.
Excuse me. Hello.
Yes, hello. We can hear you, Professor.
Yes, I want to. Do you see? Can you see my slide?
Yes, but it's too small. Would you please just switch in the other mode? Yeah, perfect.
It's okay now?
Yeah, perfect.
Okay. So guten Tag. Thank you, Dr. Kerstin Smith, for giving me the floor. I also thank Professor Kramer and his team to include me as a speaker in this international symposium on refugee health, which primarily aims to generate evidence-based policy recommendations to tackle this issue more effectively. Furthermore, I thank all the distinguished international speakers, conference organizers, and other participants for attending this symposium from various locations of the world. It is definitely a great honor for me to be a part of this timely and prestigious scientific event. Briefly, my presentation is about Rohingya refugees in Bangladesh, challenges and strategies, and my talk is broadly divided into several sections. In the first section, I will provide a brief global and Bangladesh statistics regarding displaced refugee and stateless population. Then I will provide some background information to explain who are Rohingyas and how they become refugee, and why is Bangladesh the best destination for them. In the second section, I shall highlight important dimensions of challenges created by Rohingya refugee in Bangladesh. These challenges will be mentioned from both Bangladesh and Rohingya perspective. In the third section, I shall highlight some potential strategies that could be beneficial for both Bangladesh and Rohingya refugees. In the last section, I shall briefly introduce our Rohingya-related research project, which is already granted but not yet conducted because of COVID-19 pandemic. So, and I will definitely end my presentation by mentioning some concluding remarks. Let me start my presentation with global statistics. According to the UNHCR latest report, globally 79.5 million population is forcibly displaced, of which 26 million is refugee and 4.2 million are stateless population. According to UNHCR organization definition, a refugee means they are the displaced person who has been forced to cross national boundaries and who cannot return home safely. It also refers to someone who has been to flee his or her country because of persecution or violence.
Hallo, Herr
Most
Jatta. Ich habe mir gerade dieses schöne Bild angeschaut mit diesen Hieroglyphen. Also diese
Okay, Bangladesh, most of the forcibly displaced population is internally displaced, which is around 57%, and 40% of them actually is children below 18 years of age. And Bangladesh is the 8th leading country in the world to host refugee population and one of the major hotspots for stateless population. Myanmar is the leading source of stateless population for Bangladesh. So let me briefly explain about Rohingya. Actually, Rohingya is a Muslim minority group in Myanmar. Out of country's 130 minority groups, they are used to live in the Rakhine state of Myanmar, and the estimated Rohingya population varies from 1.5 to 2 million. Although total population increased in Myanmar, Rohingya population has fallen from 3.9% in 1993 to 2.3% in 2014. This is because approximately 1.2 million Rohingya population were excluded from the last census, which was conducted in 2014. And for your information, Myanmar is dominated by Buddhism, which is followed by Christian and Muslim and Hindu. Now, the point that needs to be explained is why or how most of the Rohingya become refugee. Actually, the Rohingya problem dated back to 1948, when Arakan or Rakhine state got independence from British. Since in independence, they are targeted for expulsion by government and opposition political parties. Particularly, this problem became acute when military power came to the power in 1962. And the following quotes can explain the reason for becoming refugee. For example, quote, the rejection of citizenship rights for Rohingyas, denial of freedom of movement, eviction campaigns, violence against Rohingya women, forced labor, expulsion from their lands and property, violence and torture have made Myanmar's ethnic Rohingyas the most persecuted minority in the world, unquote. In addition, there are several remarks regarding Rohingya population. For example, the United Nations official declared Rohingya persecution as a textbook example of ethnic cleansing. And Myanmar population widely believed that Rohingyas are Bengalis and should live in their own country, Bangladesh. Because they are visibly alien in the color of their skin and language and religion, many Myanmar people think that they are Bengali migrants and entered Burma during the British colonial rule. That means they are not really Burmese population. And they are also not loyal to the Myanmar administration. So the question is that why Bangladesh is the destination for Rohingya? Actually, if you look at the map, then you can see that Rakhine state of Myanmar, which is red marked, and Cox's Bazar area is very close to each other. And the division is made only by a small river, which is called Naf River. This river, it is the width of this river is actually ranges from 1.6 to 3.2 kilometer. Therefore, these Myanmar people or Rakhine Rohingya people can easily cross the river even by boats. Moreover, some sort of similarities are found in terms of language, lifestyles, and religion between these two areas. So, how many Rohingya refugees in Bangladesh? Actually, as I already mentioned that Bangladesh is one of the largest refugee host nations in the world. It hosts most of the Rohingya refugees, which is about 1.1 million living across South Asia. And approximately 80% of 1.1 million Rohingya refugees lives in different camps, which is shown in the map, located in Teknaf and Ukhia sub-district of Cox's Bazar district, and the rest of the 20% lives outside camps or in some communities. It also hosts the biggest refugee camp in the world, which is called Kutupalong, which actually accommodates over 800,000 population. Bangladesh experiences several major waves of Rohingya influx starting from 1978. In 1978, over 200,000 Rohingya fled to Cox's Bazar, Bangladesh due to widespread persecution. Because of negotiation and repatriation process under the supervision of United Nations and other international bodies, most of the Rohingya population returned to their home in Rakhine that time. But Bangladesh again experienced second big wave of Rohingya in 1992, when approximately 250,000 Rohingya fled to Cox's Bazar. After this, waves occurred in 2016 and 2017 August. Unfortunately, most of the Rohingyas came to Bangladesh during second, third, and fourth waves, remained in Bangladesh because they lost their faith on Myanmar government since persecutions are going on and military crackdown happened in multiple points of time. Now, I will highlight some of the challenges created by the Rohingya in Bangladesh. As I mentioned at the beginning that I will divide them from two perspectives, mostly from Bangladesh perspective, and I will also focus their problems or challenges from Rohingya perspective. These challenges is again divided into several dimensions. The vulnerable conditions of the spontaneous makeshifts or tents or camps are the big challenge for public health, because we can see lack of basic facilities indicated by poor housing, poverty, overcrowding, water sanitation, and healthcare problems. And there is also widespread sexual harassment in Rohingya camps and settlements. Also, the people have insufficient income and limited livelihood opportunities. Unsafe drinking water and poor sanitation are another big challenge affecting health of the Rohingya population in Cox's Bazar, especially high level of contamination in the drinking water, either by fecal coliforms or E. coli. Water is remarkable. One study recently tested over 3,000 tube wells, and they found that 28% of the tube wells were contaminated by fecal coliforms, and 10.5% tube wells are contaminated by E. coli. Household water samples, that means point of use, were even more contaminated. For example, odds ratio was 7.42 for fecal coliforms, and odds ratio was 4.68 for E. coli. They made some interventions. They cleaned the mouth of the tube wells, and they found that the bacterial count decreased significantly because of very simple intervention, which was done only by cleaning the mouth of the tube wells. And the rate reduced to 12.9% from 28%. The second challenges, which I want to focus on demographic issues. There are several indicators I mentioned. If we compare the mean household size for Rohingya and Bangladesh, fertility rate for Rohingya and Bangladesh, then you can see there is clear-cut differences. Also, child marriage is a problem, low contraception use, and also limited antenatal care utilization, also prevalence of stillbirth are the major problems or demographic problems in the camps. Environmental degradation actually is another big challenge, especially this environment are changed irreversibly, and they have a severe impact on the ecosystem. And these changes actually occur due to deforestation caused by anthropogenic activities such as cutting down forest for timber and fuelwood and for other purposes. And there are some statistics given for you, and there is a map. You can see that how the land cover changes are occurring. If you look at the statistics, then we can see that camp area expanded by 1,356 hectares because both forest and non-forest areas converted to camps. Also, non-forest area expanded by 928 hectares because forest converted to non-forest land, and also forest area declined by 2283 hectare because of above mentioned camp and non-forest activities. What about health issues? Health issues are big challenges. The camps actually are facing double burden of disease. There are actually high rate of infectious diseases. Also, there are high rates of non-communicable diseases. I just mentioned one example from some study. According to this study, you can see that there is a high prevalence of infectious diseases among Rohingya children. And this is mainly because of inadequate coverage of vaccination, malnutrition, overcrowding, unsanitary conditions, and lack of access to safe water. Also, there are high level of mental health problems. This is very clear why this level is so high. Also, there is a low level of seeking sexual and reproductive health services. It is also mentioned by my previous speaker, Dr. Rubina Jakar. And also, home delivery without assistance of health facilities is another problem. Also, as I said already, there are also a lot of non-communicable disease burden available in these camps. I think the another important dimension which should be mentioned actually socio-political challenges. This is not last but least challenges. There are many other challenges, but since I have limited time, I just want to mention these challenges at last. So you can see there is a lot of crime, violence, human trafficking, and prostitution going on. There is a social unrest and intensified vulnerability of the extreme poor. Also, you can see the smuggling of drug, which is called Yaba, and the wide distribution throughout the country. Also, there are several examples of militant activities, because normally we think camps are the fertile ground for militant activities, illegal activities. Also, we can see negative impacts on bilateral relationship between Bangladesh and Myanmar because of armed traffickings and cross-border movement of armed insurgents from Myanmar. Also, Myanmar's unwillingness about repatriation of Rohingyas to Myanmar. So now, at this stage, I want to mention some of the possible strategies which could be beneficial for both Bangladesh and Myanmar. I just pointed out as the key points. For example, the first point, which is very necessary now, is effective negotiation for speedy repatriation process. Because Myanmar agreed, but finally they don't actually follow their agreement. So this is a big problem. We need to increase international pressure to avoid persecution on Rohingya in Myanmar. Also, we have to, we means the international organizations and bodies taking care of Rohingya issues, they should participate with the reallocation of Rohingya to Basanchor. There are some pictures I have given. You know, Basanchor is nicely developed. There is a nice building and with a lot of shelters, high-rise shelters, so that they can protect the cyclone problems and so on. So this is nicely structured, and the government spent millions of dollar or euro to make this area. This is actually a floating island near in the Bay of Bengal, which is about 30 kilometers far from the mainland. But this is a very good area. You can see this area is very nicely structured. And recently, I think the last 4th December, the first group of Rohingya population moved there, about 1,600 plus Rohingya population, and they moved from Cox's Bazar to this Basanchor camp. I mean, you can see this is very nice. And they are actually controlled by Bangladesh naval forces. And we need to raise funds collectively to improve the quality of the Rohingya population in the camps to take care of their health and other issues. Bangladesh is not enough to provide all the support because Bangladesh is also a developing country and we have limited resources. So we need cooperation and more funds from international donors and organizations to uphold or to satisfy the basic rights of the Rohingya population in the camps. We need coordination between different NGOs, governments, and non-government workers, voluntary workers, so that we can manage this problem very effectively. Definitely, we need to scale up our healthcare services because in terms of, for example, accessibility is very important in terms of coverage and addressing other health problems. Scaling up healthcare services is very important. we need to, especially the Rohingya people, need to behave in an environmental friendly manner, because they are cutting the forest and making a lot of environmental problems in this area. So they should develop environmental friendly behaviors. Also, social forestation or use of alternatives energies instead of wood or something else should be encouraged. Coordinated efforts and create international pressure on Myanmar government to obey international laws regarding human rights and stop persecution of Rohingyas in Arakan is another steps. The most important, I think, giving back Rohingyas land with citizenship right in the Myanmar constitution can be the first step to get some hope and to go back to Arakan state of Myanmar. I just briefly mentioned one of our project, which is already planned and granted, but unfortunately we could not finish because of COVID-19 pandemic. You see, our research question was what are the perception and attitudes of the local host population concerning social, economic, environmental, political, and health sectors associated with the Rohingya in southern Bangladesh. And definitely the major aim is to generate evidence-based policies based on perception of the local communities that will help guide state and non-state efforts to effectively manage the Rohingya issues in Bangladesh. And we have several objectives. First, for example, to assess perception and attitudes of the host population towards Rohingya influx in Bangladesh, to check whether their perception and attitudes differ by zones, areas, and background characteristics such as age and social class, to assess dynamics of perception and attitudes of the host population, focusing on different time points, and also to examine economic, social, environmental, and health implications of Rohingya influx in Bangladesh based on the perception of the host population. We developed a framework, a conceptual framework to conduct the study, and this framework is not very difficult, it is a very simple one. For example, the Rohingya population, when they come to Bangladesh, they will create a new environment and created by several components like job availability and competition, cultural mix, law and order situation can be changed, basic service facility and utilization can be changed. So we can see a new environment, and this environment could be mediated by, for example, distance from Rohingya hotspots, by duration of Rohingya hotspots and socio-demographic background. And actually after this mediation impact, we can see the perceived benefits and threats of the local population, which is depends definitely on levels of perception. And finally, this perception lead to the attitude. Actually, this model will follow the reasoned action theory of reasoned action, which is developed by other scientists. We are going to use a research methodology like triangulation. We are going to mix a qualitative and quantitative study. In the qualitative, we will focus on key environment interviews, and for quantitative, we will do some kind of survey, and we will focus on actually 640 samples collected from two different zones, Zone 1 and Zone 2, and from each zone actually we'll select two area 1, area 2, and this way. So the last part is concluding remarks. From my presentation, it is clear that refugees cause a lot of threats in many countries. In our case, one can see Bangladesh is affected in multiple ways. It's also a big problem, of course, for Rohingya refugees. This problem should be taken efficiently without long-term solutions. This problem can destabilize both national and regional politics. Collaboration to develop, this is my personal opinion, we can develop some kind of collaboration for doing some joint research based on multi-country institutes affected by refugees. So this is the end of my presentation. Thank you very much for your patience hearing.
Yes, thank you very much, Professor Khan, for those very insightful.
Yeah, I finish.
Yes, thank you very much for those very insightful remarks and for your insights into your future projects. I would now like to give the floor immediately to Professor Sama Jabour from the Faculty of Health Sciences of the American University of Beirut in Lebanon. And I would like to invite Professor Jabour to share his slides.
Professor
And
Khan, excuse me, Professor Khan, could you please stop your screen sharing? Yeah, thank you.
All right. Hello, everyone. Hello, colleagues, friends. I'm really grateful for the invitation to join you in this conference and for the friendship with Professor Kramer that has brought us all together to discuss the important issues in front of us. As Professor Kramer and some of you may know, I recognize some friends in the audience. I come from the conflict and health research area, not from the refugee health area. So I'm going to shift gears compared with the previous presentations in this conference today, and really try to look at the refugee health issues from a conflict perspective. So you will excuse me that some of the presentation will be a little bit more theoretical, conceptual, to try to bridge those two worlds. It's important to look at the intersections because we know from a long history of interdisciplinarity that that the intersections of fields of knowledge and the working at the margins of different disciplines is really where you can gain a lot of interesting insights and where interesting scholarship can emerge. Now,
excuse me, Professor Jabor, excuse me, could you please switch in a presentation mode because the screen is very small for us?
Okay.
Yeah.
What about now?
And now we always see your second slide. So this is more your intern mode.
All right.
Maybe
So let me again
share your screen. Maybe you share the wrong screen.
Maybe I shared the wrong screen. I could have done that. So stop sharing, and I'll share again. Here's the presentation. So share, and do you see the small slide now?
Could you press again this one?
You do not see the what I'm sharing?
We see
it. We see it. But
how about now? Do you see the big slide?
No, but don't worry. So you continue like this. We can still see it. At least I can see it.
It's very strange because what I've done is just simply I'll try one last thing before we can, so that we don't waste time. I'm going to make this a slide, and then I'm going to share screen right now. Where is that? Here you go, slideshow. How is this?
Fantastic.
Perfect.
Okay, it works. Okay, wonderful. So I work on health in the Syrian conflict, and we actually, from that, we built towards global work on health and conflict in a much larger framework that I will speak about. From that, I'm going to take a few perspectives to really bring into the discussion of refugee health. So I'm not going to present data-heavy presentation, but rather raise issues that discuss areas of tension, continuity, and disjuncture in our respective fields of inquiry and practice, meaning conflict and health and refugee health. There is plenty of data and reviews, and I can certainly direct any colleagues who wish to see some of this data to some of our work, as well as work from other groups on this. My major question that I'm asking in my presentation is that what is it that has been traditionally emphasized in discussions of refugee health, taking the case of the Syrian conflict, but also some other conflicts in our region and globally. And what is it that perhaps can change to bring a stronger conflict perspective to those discussions? So I'll start with giving you a bit of background about some of the work we do on conflict and health. This is our faculty, established in 1954, and we lived through a whole civil war of 15 years in the 1970s to 1990. Three important books came out of during that period, two during the war and one after. But interestingly, when you see the table of contents of this work, you find that conflict itself is not a subject of critical inquiry in those books. Rather, they look on traditional reviews of health issues, health and demographic issues and whatnot, and health services issues. So when the Arab uprisings came in, we thought that this is about time that we engage differently with these mega social events, social and political events in our lives, and engage with them in a critical scholarship. And this is where we developed the Health in the Arab World Lancet series that looked at various dimensions of health, including the impact of war, which had been just starting up in Syria by the time we had finished this in 2013, got published in early 2014. By the time this went to publication, the Syrian conflict had already really expanded, and with it the refugee situation. So we launched this Lancet Commission, and in this Lancet Commission we have several thematic groups. One of them, I will point here to the thematic group C that looks at refugees and host communities, and thematic group D that looked at health systems, including health systems for refugees as well. So the refugees is core of our inquiry, but it's really looked at, contextualized in the conflict of in the context of conflict, and I will expand on what that means. So I'm going to just give one example of how to examine issues at how we've examined issues at the intersection of conflict and health. The attacks on healthcare has been a hallmark, a defining feature of this conflict, and we published this work on the weaponization of healthcare, but also looked at the implications of that weaponization of healthcare for health workers and their immigration and their displacement from the region. Alexander would know that because of the Syrian conflict, almost 1,100 Syrian doctors left Syria to Germany alone, just to Germany. This is a huge loss to the health system, which had probably a total of practicing physicians of 25,000 physicians prior to the conflict. Nobody knows, because a lot of doctors were registered but practicing in other countries. And when we looked at the scholarship around this, you could identify issues that are both driving the displacement of those health workers to become refugee health workers in new health systems, particularly in Europe, but also in Turkey, but also issues that forbid them from practicing and keeping up with their medical practice. For example, in Lebanon, where they became essentially refugees like everybody else, forbidden from practicing. So we always wanted to look at the issue of the refugee in relation to the conflict, the driver factors. Now, some of you remember Fukuyama's book, where the period of the 1990s after the collapse of the Soviet Union was, hey, we're all gonna live great peaceful futures. This did not pan out, and as you can see from when we witnessed since the decline in conflicts in the 1990s, we now have seen an upsurge in conflicts over the past 2.5 decades. So there is a problem that is going to persist with us and generate, unfortunately, more and more refugees and displaced people, particularly in consideration of the factors of climate change and whatnot. And this led us to launch this Global Alliance on War, Conflict, and Health. Now, specifically on refugee health, you will see that in the Syrian conflict is actually, I point you to the right side of the slide where it said outside Syria. This is essentially what means Syrian refugee. The scholarship on the Syrian refugees expanded quite a bit over the duration of the conflict. So reaching 264 publications in 2019. Actually, there is more publication on Syrian refugees than there are on health inside Syria, where the research amounts to only 89 publications as opposed to a factor of 6, almost 570 publications, research publications on refugees outside Syria, obviously. And these are the themes where you can see that the health status really dominates the consideration of on refugee issues. And we can certainly review what issues have been addressed, but I will spare you these. Just will make them available so colleagues will have a chance to refer to them. Now, I would like to really spend a bit more time reviewing learnings at the intersection of conflict, forced displacement, and migration. The first issue is that words matter. As you can see, we have tended to focus a little bit more on the drivers. So we discuss forced displacement a lot more than we actually discuss refugee health. These two dimensions of looking at the same issue are distinct, and they're really different. One is looking at the drivers and one is looking at population health outcomes, but we feel that those are complementary but necessary. A lot of the time, refugee health issues do not get to really discuss the drivers as much as they should be discussed. The other aspect is that in almost many of the conflicts in our region, the forced displacement, whether it's of professionals such as health workers or non-professionals, have been preceded by a long history of migration. And I'm going to look at that in the next few slides. Now, the framework of how we look at things makes a difference. So I've listed here in the slide the various frameworks that we have come across as we were researching health in the Syrian conflict, including but not limited to the refugee subject. And as you can see here, what we have is that we have this really compendium of frameworks and approaches and considerations. And the question that comes is that do these expand our understanding, expand our community of scholarship, or do they actually create silos separating those who work on refugee health from those who work on humanitarian health, from those who work on conflict medicine, and so forth. And this is a challenge that I really leave with you to answer, and hopefully we can engage with it in the Q&A. The second dimension that comes up as important is that we have to really see displacement in the long term. Displacement in this region actually long preceded these conflicts, and some of it you could say are voluntary displacement or migration to seeking out better jobs. Some of it is not forced, is not voluntary, such as what has happened within Syria when people migrated to urban slums because of climate change and all of that. But all of these long-term views of migration and displacement in our region really create risk. they create risk of conflict, and that has been argued very strongly by some of the colleagues who are making links between the climate change and the contribution to the demographic change that led to population hotspots protesting against oppression. The other dimensions of displacement that becomes important when we dig deep beyond just the title of displacement is that displacement is really a subject that has to be qualified. You have to discuss what type of displacement, you have to characterize it in order to really understand its implication. And those implications are eventually seen in two dimensions: conflict and political violence, but also social and economic violence. So when for example, if you take the situation of a large number of kids being out of school, what we have called bad displacement, or you take what is called charged displacement, which is produced by identity politics. And the risk of refoulement, all of that really creates further inputs into future risk. So you enter a vicious cycle that you cannot break. And this I've used this slide from 2018 every time I've spoken about refugee issues, because it really is striking issues for us to see how much of the future, not just of Syria, but also the future of this region, is shattered through children being out of school. I mean, this is a travesty that we will suffer from for decades to come. And when you look at the reasons of why kids are out of school, you see tuition, no opportunities, and transportation costs being key factors. And as a matter of fact, all of these are addressable factors, but the mechanism to address them are not, unfortunately, in place. Now, I won't comment a lot here, but to only leave you with a couple of thoughts here. The first is regarding the whether we are really using discussions of the refugee health and displacement as endpoints of this discussion, so to speak, so that we look at them, we focus on them, or whether we use them as entry points to discuss the ecosystem that brings all the way the drivers of conflict all the way to the displacement. So look at the spectrum of issues that are really important to examine in a comprehensive ecosystem research framework. And obviously we will argue that the framing is important. Whether you frame the issues as human rights or you frame them as capabilities, so moving up from rights to actually capabilities, building up the potential of refugees to regain meaning and regain lives and regain livelihoods. It makes a difference whether it's charitable versus human rights versus capabilities. You can also argue that there's a spectrum along that line as well. This is my last slide, and we have I've summarized what we have, some of the observations that we have made in reviewing the literature on refugee health in relation to the Syria conflict, but also in discussions with many key informants and colleagues working on the Syrian conflict, but also outside. The first is that the framing of the refugee health is commonly discussed in isolation of drivers, and the farther further you are from Syria geographically, the more so it becomes an autonomous subject, so to speak, as opposed to to being integrated with the political drivers. There's less attention to the consideration of refugees as political subjects, as subjects who have political experiences, social experiences, who live these politics and continuing basis despite their displacement thousands of kilometers away from their home countries. Now, the second matter is looking at the ethos of refugee health. Is the refugee health a technical matter for the receiving health systems, or is it a human rights matter reflecting solidarity or benevolence, or are even more radical approaches being adopted, such as the capabilities approaches, which we don't actually see very often in this literature. The third dimension is to look at the scope. You know, in this amazing conference today, we've discussed refugee situations in Turkey, in Greece. Now we're discussing Lebanon, Syria, and you know, all of those are commonly discussed as almost disconnected refugee situation, when we actually, what we need to do is to actually bring them together as part of one story and figure out, you know, how we create common frameworks for understanding, but also synergy for action on refugee health issues. You know, obviously that the disconnection of seeing those situations is also reflected in the fragmentation of the refugee scholarship, where you know, you have focus on some areas but not others. You have a focus on certain geographies to the exclusion of others. So that creates obviously opportunities for strengthening our work on refugee health issues. And commonly, perhaps among the most common observations we've seen in this literature and in the interviews, is the limited consideration of pre-conflict issues. So while at least some of the refugee health literature considers conflict dimensions, the pre-conflict dimensions are universally almost ignored. And you know, the refugee who arrives in whatever destination carries with them not just the conflict, they carry a whole excuse me, they carry a whole life history that preceded the conflict, and that determines their health behaviors, their health system seeking approaches, and all of that. And then the last observation, considering looks into whose problem it is, how it's framed, whether it's the receiving country versus the origin countries, and what is considered really a mandate for, who has the mandate for action, and is this mandate considered across the refugee platform, so to speak, extending from an internally displaced all the way across countries of displacement, or is it considered a local mandate where I will deal with refugees in this locality where I have refugees, everybody else takes care of their own refugees, we don't talk to each other. So I'm hoping through this presentation that I've made the case for us to talk to each other and for us to consider the spectrum of issues and to really consider conflict perspectives as we consider refugee health in this region and elsewhere. Thank you very much. I hope I didn't go over time.
Thank you very much, Professor Jabour, for your presentation. And I would now like to move directly on to our final speaker in this session, Professor Amir Hossein Takian. And I would like to invite him to also share his slide and start his presentation on refugee health as the building block for
good afternoon. Can you hear me well?
Peace and sustainable development in Iran. And Professor Takian is Yes, we can hear you, please.
All right.
We don't see your slides.
Okay, just give me a second, I will do that.
Please take
Can
your
you see
time.
them now?
Yes, we can see them now. If you maybe just start the slide.
Okay. All right. Is it okay now?
Yeah, now we see them perfectly. Thank you very much.
All right. Thank you very much, Kerstin. Good afternoon. It's my honor and pleasure to be with you this afternoon. As the last speaker, I know we are running out of time, and so I try to be very, very brief. And actually, when others were presenting, I was somehow shrinking my talk because I knew that we have just 15 minutes to the end of the whole session, so I don't know whether we can do that. I would like to thank Professor Alexander Kramer, my great friend and collaborator, for inviting me for this very prestigious symposium. And thank you, Miriam, Vanessa, Fatima, and others behind the scenes who have been helping to make this happen. Actually, what I want to do this afternoon is sharing with you some thoughts about another aspect that we need to look at when we discuss about refugees' health. All great presentations since this morning. You shared with all of us from Bangladesh to Pakistan to Greece and other places in Germany, how actually refugees' health being treated. One thing which is very important is refugees' health is a part of sustainability, is a part of peace, is a building block of sustainable development. And in my 15 minutes of talk, I would like to somehow concentrate on these issues of sustainability from the angle of health as a right, as a challenge, as a paradigm, and health as one of the main pillars of sustainable development. If you look at the health as the WHO, we can see that health is physical, mental, and social well-being. It is a right, and it is very complex, and it is very multidimensional. So the business as usual cannot address the health issues. And health is like, in order to reach healthy societies, because if you look at the right-hand side, health is a precondition, outcome, and indicator of a sustainable society. So this is a kind of universal value and shared social goal and political objective for all. And all is the main keyword when I'm talking about refugees' health this afternoon, because refugees, displaced people, immigrants, they are part of this all, they are part of the society. And often we forget that these people are like others. We are witnessing the largest number of refugees. And that's why, as the UN Secretary General says, this is the obligation under international law to provide everything necessary. It's not just a matter of solidarity, it's not just a matter of protection. This is the matter of international law. This is the matter of humanity. So we can't deter people fleeing from their life. They will come. The choice is whether we manage them humanly. And for the rest of my talk, I want to bring to your attention that when we talk about sustainable development goals, which is the global agenda for sustainability, which is the global agenda for humanity, which is the global agenda for living in peace. And specifically, if you look at this middle, I'm talking about positive peace, which is again, something not just having conflict or war or lack of the sustainability. Is more than that. It is well organization, it is rule of law, it is lack of corruption, it is integration of everybody into the society, so leaving no one behind. So there is no health without peace. And that's why when we talk about the pillars of sustainable development, where we see here, peace, partnership, and people, prosperity and planet are all part of it. And my argument today is universal health coverage, which is the most important building block of sustainable societies, is within refugees' health. And this is, to be honest, more appealing when we look at some countries. This is the latest statistics I could get from the UNHCR. You can see that almost 1% of the world population are almost displaced or refugees or immigrants. And then we can look at some countries at the bottom. We can see that some countries in our region are among the most host countries for the refugees. And Iran, which I will come to the number in a minute, is among the countries who accepts refugees. And the thing is, we don't have the huge number. We do have huge number of official refugees, but in addition to that, we have the huge number of undocumented and unofficial refugees, which somehow hinders our pathway towards universal health coverage. Then, added to this, the exacerbating situation, which comes from this recently published report, Ecological Threat Register 2020, you can see that among the 20 countries with most displaced people from disasters, for instance, Iran has been the 6th. So you can see that because of the natural disasters which are happening in countries like Iran, and then Afghanistan, Pakistan, and some countries in sub-Saharan Africa, my country is very prone to displace people in 30 years to come. Where is Iran? You know, we are in the West Asia with a population of almost 83 million, very similar to Germany. We have been enjoying a good situation in terms of our health system and our health outcomes. I don't want to go to the numbers. And by the way, I don't want to go to very heavy data presentation because you know what's happening in terms of the numbers. What I would like to invite you to think about is universal health coverage as a building block and how Iran is partially addressing this universal health coverage, because without which we will be witnessing the unsustainable societies being exacerbated by COVID-19. So we have been doing a research with my colleagues at Tehran University of Medical Sciences to understand the challenges of providing care, primary care, secondary care, and the different kind of rehabilitation services, mental health services to Afghan refugees in Iran. If you look at the numbers in here, we can see that almost 1 million Afghan refugees, documented Afghan refugees, live in Iran, and almost 2.5 million undocumented Afghan refugees have been living in Iran in the course of last 4 decades. Added to that, there are almost 30,000 Iraqi refugees from the war between Iran and Iraq back in 1980s who fled the country. Now they live in Iran. But as you can see, the majority of our refugees are from Afghanistan. And as I said, the challenge that we have is we do have much more numbers of undocumented and illegal refugees compared to the refugees who are documented. But the government of Iran have been granting the refugees free access to medical services, education, literacy classes for out-of-school children and labor, and the different kind of services that they have. If you look at our health system structure, you can see that we are somehow experiencing a kind of unique structure in our health system. We are perhaps the only country at this big scale in the world that have made the medical education into our service. That's why under the Ministry of Health and Medical Education, which is a kind of very rare name and among the ministries of health globally, you can see that we have 67 universities across 31 provinces. And those universities are responsible for providing secondary care, primary care, and everything up to the very remote areas and villages. So that's the system that we have been using for refugees' health as well, wherever the refugees are. If you look at some numbers, I just want to show you the differences in terms of the characteristics of the refugees and the financial resources available. My great friend Samir was talking about Lebanon. So we can see that, for instance, if we compare Iran with Lebanon, in terms of the number of people who are refugees, of course, Lebanon has been hosting a number of Syrian refugees and others. But Iran, we have almost 1 million Afghani and 2.5 million Afghani who are undocumented. Then if you look at the fiscal space, you can see Iran is somehow suffering from the greatest fiscal gap for provision of international donation and international aid for the refugees. Added to that is the very difficult situation of my country in terms of suffering from the sanctions, from the unilateral sanctions, from the global sanctions in the course of last 4 decades, and specifically 2 decades, and more specifically in the course of last 2.5 years by the unilateral sanctions imposed by the United States and the lack of financial resources that we have. So you can see that the per capita donation we are receiving for our refugees at the bottom of this is much less compared to other countries in the region. But despite this very difficult background, we have been providing a different kind of services for refugees in the course of last 4 decades. This, on the left-hand side, you can see some of the national laws and legislations which somehow mandates the government of Iran to provide health, education, and all public services for refugees, either free of charge or with a very small nominal fee. For instance, the 1951 Convention related to refugees, the mega policies for health by the leader, universal right for social security in Iran, which includes refugees, the national development plans, different ones. Now we are ending the 6th one, and the constitution of Iran, other things. If you look at on the right-hand side, you can see that similar to Iranians, all refugees, including undocumented one, can access to free primary healthcare services free of charge. And this is very important because our primary healthcare system is very robust and very comprehensive, specifically in rural areas and small cities. And many refugees who have been living in those areas, just bear in mind that almost 3% of refugees are in the shelters. So 97% of those are embedded in the society. They live with other people, other Iranians within the society. So you can say that they use all services like vaccination, mother and child services, nutrition counseling, the infectious diseases problems, the medicine and thing free of charge. For hospital care and complex and expensive care, they pay the maximum of 10% co-payment. And I will come to that recently, in the course of last 5 years, we have started some other things in order to bring more financial capacity for the refugees in Iran. There are some special arrangements for mental health care. Some of you in the audience, you remember that in the World Health Summit 2 years ago, I talked about the mental health care services, from the counseling, from the medicines that we provide, from the special clinics, for instance, in Tehran and other big cities that we have for increasing and enhancing the mental health conditions of the refugees as well. One thing which we are really proud of is the NGOs and charity organizations who support refugees, and I will come to some of those names in the next slide. And those are organizations which provide even the 10% co-payment if the refugee and his family cannot provide. They are coming in and they pay for that. Access to community-based rehabilitation services for refugees with disabilities. For instance, blind people, paralyzed people, deaf people. We do have a number of those services embedded within our PHC. One specific initiative, which I would like to mention, is improving maternal health in Afghanistan and Afghan refugees in Iran through South-South collaboration. This is a project that I was leading as a national coordinator. It started back in 2017 with the UNFPA and the governments of Italy. So we secured the grant, and then we provided a specific education and capacity building in Kabul University in Afghanistan, and providing a specific maternity wards for Afghan refugees in the south of Tehran, which is a very deprived area, using this money and facility being topped up by the government of Iran. And this is among the projects that we have been doing to address maternal mortality rate in Afghanistan and for Afghan refugees in Iran, which is among the highest in the world. And last but not least, full free support and insurance during the COVID-19. When COVID-19 happened, you know, Iran is the most hit country in the region in terms of the casualties and the consequences of COVID-19. There are some new rules that if the refugee person comes with COVID-19 or he or she is suspicious, even on the bed of the hospital, the refugee gets the insurance free of charge, and all services will be provided free of charge. Here at the top, this comes again from the UNHCR office in Iran. You can see that the funding of refugees in Iran, unfunded programs are much higher, almost five-fold more funded programs. That's why I'm saying that we are suffering from the huge fiscal gap. These are in the middle, some of those charity organizations like Mahak, for instance, for cancer, and Daheshpur or Zanjire Omid, which is the chain of hope, which are responsible for providing services. And these are some photos, real photos from some places, for instance, vaccination for Afghan refugees, community-based rehabilitation, health promotion activities, and providing different kinds of care for Afghan refugees and other refugees in the Iranian context. One specific thing which I would like to bring to your attention is Iran back in 2014 started its pathway towards universal health coverage, which is called Health Transformation Plan. Health Transformation Plan is the Iranian government and the Ministry of Health comprehensive program to reach universal health coverage by 2025. So we started, for instance, to provide free insurance for our citizens and the immigrants. So it was a contract between the UNHCR in Iran and the Bureau for Aliens and Foreign Immigrant Affairs in the Ministry of Interior, the Ministry of Health and Education, and the Iranian Health Insurance Organization. It's called UPHI. This is the Universal Health Insurance Program for all refugees in Iran, free of charge or with a kind of very minimal fee. Out of this, we have been providing a kind of financial sustainability for refugees to enjoy the services and to have access to the quality services with reducing the financial hardship. The money comes from the government of Iran, very small money from the UNHCR, and 10% co-payment by the Afghan refugees. But there are some other mechanisms if they cannot do that. And this is called Bime Salamat Vijay Muhajirin, which is the refugees particular program for health insurance. And if you look at this blue table on the right-hand side, you can see that if refugees with insurance, there is admission to the hospital, inpatient services, and outpatient services. There's a very small co-payment like Iranians, and they can enjoy the services. If they don't have insurance, they can still enjoy the services. Even they are undocumented immigrants and refugees, they can enjoy the services, all the services which I mentioned, but the cost is a little bit higher just to encourage them to go and get the insurance for their families. And these are the list of some services for mental health, for instance, I've put as a kind of summary. I don't have time, and for the sake of this meeting, because I know we are running out of time, I don't go to the details of this, but these are the things that we have been doing. I want to finish by telling you some challenges of providing healthcare for refugees to Iran, in Iran. Despite all these efforts by the Ministry of Health and the government of Iran and the charity organizations, there are still some challenges. Even though Afghan refugees are speaking the same language as Iranian, both speak Farsi, but with different dialect. But the thing is, there are some socio-economic features and the personal issues of refugees, for instance, financial problems. You won't be surprised, perhaps, to hear that out of 950,000 documented refugees, almost just 10% of them applied for the insurance, which was really, really cheap. They didn't, because still they're suffering from the financial problems. Many of them are illegal. Specifically, in the course of last 3 years, they have been afraid that they will be deported if they come to seek for care. The lack of valid identification documents, unsuitable and work conditions, they are very low in terms of literacy. Some of them have of education, the high prevalence of mental illnesses, and cultural beliefs and poor health behaviors that they have. Language differences still bites and limitations in benefiting from interpreters, and sometimes Afghans' mistrust in the healthcare staff in Iranian healthcare staff is an issue. That's why, for instance, for maternity, we created a hospital which is run by Afghan staff in the south of Tehran. Some organizational issues, the lack of insurance coverage, as I mentioned, the lack of a screening system upon borders. The borders are not very much well controlled, so that's why they are suffering from the control of these people and lack of registration, inadequate organizational support, and low coordination among different providers. In Iran, we have been suffering from the weak coordination between different organizations. And at the social level, the negative attitudes of some Iranians and healthcare providers to refugees. I'm afraid to say that there are some places in Iran still Afghan refugees cannot travel, cannot go, and this has been adding to the burden of this. The good thing is with Professor Alexander Kramer and Parisa Rahimi-Tabar, one of our researchers who is doing her PhD at the University of Bielefeld, we are addressing and we are comparing the status of refugees' health in Iran and Germany, Afghan refugees in Iran and Germany, and hopefully we will be providing some kind of connected lessons and learning lessons from this. I would like to finish by inviting you to a very famous poem from Saadi Shirazi, who was among the greatest Iranian poets in 13th century. It says in Farsi, Bani Adam a'za yekdigaran ke dar afarinsh ze yek goharan. The translation would be, human beings are members of a whole. In creation of one and soul. If one member is afflicted with pain, other members uneasy will remain. If you have no sympathy for human pain, the name of human we cannot retain. That's why we need to look at this as a humanity issue and making sure that no one leaves behind, including all refugees in every society. Thank you very much for your attention.
Yes, thank you very much, Professor Takian, for this very interesting and impressive presentation. We have now some 10 minutes for some very short questions and also please some very short answers. So I would like to invite the presenters of this session again to maybe put on their cameras so that we can have a short panel discussion here. Maybe I would like to start with one question to Professor Khan from the audience, or there were several questions going into the same direction about the Basan Char, where the Rohingya are supposed to be relocated. So the question is about the infrastructure, the worries that those areas might be very much affected by the outcomes of climate change. And so the question is, what will be kind of the situation of the Rohingya in this area? Professor Khan?
Professor Khan?
Yes, so thank you.
Mm-hmm.
So actually, it's a very good question regarding Basan Char. You know, Basan Char actually is a floating island, which is actually formed in 2006. And by this last 14 years, this land actually becomes stable. And that's why Bangladesh government actually spent $350 million to make this arrangement. You know, there are many houses, many shelters, and also there are hospitals, there are educational institutions. So it's a complete arrangement so that people can enjoy their lives over there. Only problem is it is little bit isolated from the mainland because it is in the Bay of Bengal and 39 kilometers from the mainland. So some Rohingyas, they are afraid of like whether they can communicate with others. They cannot easily go to the communities because now in the Cox's Bazar, it is very easy to go inside. You know, there is a mix of population. But if they go to this Basan Char, maybe it could be a big problem because they will be monitored and they cannot go inside the community. So that may be the reasons why they are afraid of going there. But after the first group who moved actually in Basan Char on the last only 4 days ago, I saw some interviews and they feel very good. They expressed their satisfaction, and even they are trying to bring their relatives who are living in the Rohingya camps in Cox's Bazar, because this Cox's Bazar area is not properly maintained, is not properly structured. There are environmental problems, there is water scarcity and other problems. But if they go to Basan Char, then this is designated area, and Bangladesh government is trying to make or give all the facilities over there so they can live there very good. You know, so I think it is just one kind of a misconception about the Rohingya population, or they think they will be isolated. If there is any storm or like cyclone, maybe they will be in big problem, but this is not the case because there are so many shelters are already made for this purpose. So I think this perception is not really correct.
Okay, thank you very much for your answer. Professor Kramer, you had other questions maybe for us?
Yes, thank you very much, Kerstin. I have a question for Rubina Zakar. Rubina, so you talked about the influx of the Afghani refugees, and this has a very long history in Pakistan. And I wonder if there are also some best practice models, or one or two best practice models, for example, that have proven to be successful or work very well, in spite of all these very large differences that people have to live in camps. And you have also talked a lot about the women, the situation of women, pregnant women, early marriages and so forth. Are there also some kind of developments in a positive direction that you could talk about? So this is the first question to you, and another one would be regarding the surveillance of various diseases and research. I mean, you mentioned that respiratory infections, skin diseases, is that systematically surveyed? What do we know about this? Yes, thank you very much for your presentation.
Thank you, Dr. Kramer, for the questions. For the first question, in Pakistan, United Nations High Commissioner for Refugees, they are working a lot for improving the living conditions of Afghan refugees. And especially they are working for improving the education and enrolling children from Afghan refugees to schools, and they are working for women education as well. One of the program which is from the healthcare department, which is going on, it is related to lady health workers program, because many of women, they can't go to health facilities. So that's why this program is started around in 90s to improve the health care utilization of women, particularly living in disadvantageous conditions like in refugee camps. So this lady health worker program is because these are the women. Some of the women who are educated, for example, not much educated, if they have taken 10 years of schooling, they are recruited from the Afghan refugee camps for this program, and they are trained for 2 years for providing primary health care to women at the doorstep, and especially to the families, and they provide the health information to the families, and they also take care about the vaccination status of the children. And in case of women, they can't go to hospitals, they provide transportation to these women. So such kind of program, it has improved the health status of these women. And one of the major issue was related to use of contraceptives. So these healthcare providers, which are lady health workers, they usually provide contraceptives at the doorstep families, so the contraceptive prevalence rate can be improved. So there are many other programs are also going on. For example, improve the employment status and provide some opportunities to these families for earning opportunities, and involving women in the microcredit. They provide the microcredits to these refugee women, so they can be involved in small household businesses. So they don't need to go anywhere. They can, if they have some kind of skills, for example, if they are good in embroidery or handcrafts, so they are provided some amount to start such kind of business, and these women, they are then involved in small businesses to earn little money for their families. So these are some programs which are going on. And regarding the violence against women, it's still a big problem, not only among Afghan refugees in Pakistan as well, but a lot of things are going on, and things are improving, because we don't have valid statistics related to the health status of Afghan refugees, because I have collected some data. It was on the basis of small sampled studies. So we don't have big surveys where we can see the real disease burden. Specifically, I read some articles related to skin disease, because they have mentioned that the leishmaniasis is very much common among the people who are living on camps. So because the authentic statistics is not available, so we don't know exactly that what kind of real health communicable or non-communicable diseases they are experiencing. But with respect to violence against women, one of the main thing is to empower women, and many of the programs are going on related to women empowerment in Pakistan. But with respect to Afghan refugees, it is very difficult, because Men, they don't allow many of the organizations which are working against violence related issues, they don't allow them to enter in their localities. So many of the organizations, they are experiencing a lot of problems. So this is the main issue still, which is not catered in the Afghan refugee camps. So, but government is trying to provide opportunities for women, and hopefully if more women they are in education, then the problem can be solved. Thank you.
Thank you very much, Rubina.